Welcome to tonight's Immunisation Coalition webinar. The topic tonight is on pertussis. It's a 2023 update. This is particularly well timed considering the number of cases we have on whooping cough this year, particularly in the last quarter or 4 months. And I'll talk a little bit about that before introducing our guest speaker tonight. My name is Andrew Minton. I look after the education services on behalf of the Immunisation Coalition. My colleague, who's working in the background tonight, Anastasia Barron, our events manager, so she's brought a lot of this together, and so really appreciative with her time and putting this webinar together. So firstly, I'd like to acknowledge the traditional custodians of the various lands of which we work. And welcome all Aboriginal and Torres Strait Islander peoples that may be on this webinar tonight, particularly the Gadigal people of the Sydney area of which I reside. I'd like to pay my respects to myself and on behalf of the Immunisation Coalition to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands, the animals, and the waters of Australia. So just a bit of housekeeping. If we just click over to the next slide, please submit your questions. This is normal and you all know this, so please submit your questions through the Q&A box. Perhaps not the chat. You can use the chat for comments and you're welcome to answer those comments in the chat. If you're this first time asking a question, just maybe put FT in the beginning so I know it's first time, and I will endeavor to get to your question. If we're not able to get to your question for whatever reason, we're running out of time or I've missed it or we can't answer that question, it will be available, the answer will be available in a transcript in about 1 week's time when we provide the recording on our website for you to access, and we will provide a direct email to let you know when that recording and that transcript is available. There'll be a short survey at the very end. It takes about 3-4 minutes. If you could fill that out just so we can improve our webinars ongoing, that would be very helpful. And yeah, as I said, the recording will be available in about a week's time. So this is recorded. And I just wanted to have a bit of fun and share some numbers with you. Many of you will be across these numbers already. Specific to whooping cough, this year we're at 27,100 and a few cases year to date. That is 31 times more than last year, and it's growing. If I look at Q2, which was just under 10,000, and Q3 cases were at 14,300. So, you know, it's almost 50% more, and we still don't know whether or not we're over the hump. If I look back a couple of months' time, we're at 25 times more compared to last year. So it is growing. And interestingly, I looked historically at the number of cases going back 15 years. And I had to go back 15 years to have a look to see, you know, what numbers there were similar to that of this year at 27,000. So in 2009, 2010, 11 and 12, there were 30,000, 34,000, 38,000 and 24,000 cases. So an average of just over 31,000 cases. And that was 4 years in a row. Now, there might be some reasons for that, I'm sure, but then we had to wait 3 more years until those numbers were similar at 24,000 cases again in 2015, and it rolled over into 2016. So we know that, well, there is a suggestion that pertussis has a 3 to 4 year cycle. Looking at 2009 to 2012, that doesn't appear to be the case. But with the decrease in 13 and 14, that third year did spike up to an average of 24,000. And then it dipped down to 12,000 cases per year, and then COVID hit. So that kind of upset the apple cart. And then in 2023, we're at 2,451 cases. And as I said, this year, we're at 27,000 cases and counting. So don't really know if it's every 3 to 4 years. It seems to be a concurrent 2-year process, and it'll be interesting to see what next year's pertussis cases are. And I did another just in the last 30 seconds, and this is relevant to Andrew Beard's talk I presented tonight. I did a little analysis on cases per capita across Australia. There's no distinction between age group, and there's no distinction between metropolitan and rural, but it's just a sort of a fun exercise. And of looking at this year, New South Wales and Queensland have the highest cases per capita. That's not necessarily the highest population, because Victoria is the second highest population. But New South Wales and Queensland had anywhere between 8 and 12 times more than any other state or territory on a per capita basis. So that tells me that if New South Wales and Queensland sneezes, Australia catches a cold. So, there might be some strategy around there. If an outbreak does occur, regardless of where it occurs, it's these two states that tend to be hit the most, at least from this year. But interesting to see what it was in the previous years. And vaccination rates for children are very high, 92 to 96% on an average nationally, from 1 year to 2 year and under 5. So the vaccination rates are good for under 5s, but it's those outside of that age group which are probably causing the transmission and spread of whooping cough throughout Australia. So just a few interesting facts there before I introduce tonight's speaker, which I will do that now. If you could give me the next slide, please. So tonight's speaker is Dr. Andrew Beard. He did present for us graciously last year, and that was also very well received. So Dr. Beard is a general practitioner in St Kilda Medical Group, Melbourne. Is also a medical advisor for a medical defence organisation. Andrew is a member of the Immunosenescence Coalition and has been for some years, and is part of the Primary Care Education Committee, who advises on select topics in GP meetings and also in primary care meetings, of which we have one coming up next month on the 19th of October. So a little plug there. And those details are available on the website. He has a background in rural general practice and is passionate about education and providing practical medical education to healthcare professionals. So with that, I'd like to introduce Dr. Beard and for him to take us through his talk on pertussis. Thank you, Andrew.
Many, many thanks, Andrew and Anastasia, for inviting me and for your generous welcome. Thank you. And thank you for attending to our, I see 230 participants, and welcome to this evening's session. I'll start with saying what we're going to be discussing, where there really are 3 learning objectives this evening. First of all, think pertussis. Secondly, vaccinate. And third, vaccinate again. So those are really the 3 take-home messages. So if you'd like to leave at this stage, you've really got the take-home messages even before we've started. So let me talk you through it. Well, another introduction. This is Bordetella pertussis. It looks like a sort of a 12-legged spider or some sort of alien. But this is the what we're dealing with this evening. So here's Bordetella pertussis. Next slide, please. And I'm going to introduce Jules Bordet. Jules Bordet first isolated the bacterium which now bears his name in 1906. He was a Belgian immunologist. He later was awarded the Nobel Prize for Medicine. That was in 1919. And I'm going to mention at this stage, just to stress that pertussis is a human disease. There's no other vector, there's no animal reservoir for it. And it's also a notifiable disease. And that's important when we look at collecting our statistics around it. Next slide, please. So going to introduce the clinical course of pertussis. There are essentially 4 stages and 4 tools for diagnosing it. The incubation, catarrhal, the paroxysmal stage, and the recovery or convalescent stage. Individuals are infectious from the onset of the catarrhal stage, and really till about 3 weeks after the onset of the catarrhal stage. What is the paroxysmal stage? Well, the classical features of that are episodes of rapid cough, which is due to tenacious mucus in the tracheobronchial tree, up to 15 to 20 of these paroxysms in every 24 hours, and typically more common at night. And following a paroxysm, there is typically an inspiratory whoop, getting the breath back, and that may be followed by a vomiting episode. So an unpleasant and distressing experience, particularly for infants who are most vulnerable to the effects of pertussis, who may become cyanosed as a result of these paroxysms, may become exhausted and therefore have impaired feeding and the consequences of that. Next slide, please. So really just putting some figures around those stages. The incubation period, typically 2 weeks. In terms of exclusion, typically 21 days, but this can be reduced to 5 days after taking antibiotics. It's highly communicable, thank you, in the catarrhal stage before the paroxysms start. But essentially, it's not communicable 3 weeks after the onset of the cough or after the antibiotics. Next slide, please. So antibiotics are helpful, but really they're helpful for protecting contacts. They're not so much helpful for helping the individual who has pertussis. So it's a minimizing transmission. Certainly recommended if the diagnosis of pertussis is made less than 3 weeks after the onset of the cough. Thereafter, after 3 weeks, there's no benefit because the infectivity of pertussis is considerably less, if not nil. There are antibiotics which are available, azithromycin and clarithromycin and Zeptrin, cotrimoxazole. There is a problem with azithromycin. To get that on PBS, PBS only provides 3 days supply, so we can't get the 5 days on PBS. However, clarithromycin is available on the PBS, both for the solution, the liquid, and for the tablet formulation. So clarithromycin is probably the preferable in terms of availability. They're equivalent in terms of efficacy. Next slide, please. So what we're going to look at now, we're actually going to look at the different age groups because it's a different clinical illness, different vulnerability, although the treatment and approach is the same and vaccination is the same. Next slide, please. So this slide is from the World Health Organization. It's looking at cases in Australia between 2000 and 2022, and really sort of echoes what Andrew Minton was saying initially. It shows that here we've got 2 peaks on the number of notifications in 2011 and in 2015. So that does fit the 3 to 4 year cycle of peaks of pertussis. So these data are across all of Australia. They're not jurisdictional, and they're number of notifications. They're not incidents. So that's helpful data just to help us along. And these data are from the National Notifiable Diseases Surveillance Survey, the NDDSS. And again, echoing what Andrew said at the start, these are showing a number of cases across Australia, and this is from 2000 and I can't see on the slide, up until 2021. But again, showing us the 2 peaks, the peak in 2011 and the peak in 2015. And the other feature to pick out there is what happens in 2021. This is pandemic time, so we don't have communication, and the levels and incident and notifications drop down. And this is bringing us up to date. So these are data from the NDSS and showing us the number of notifications, again, across Australia from 2019, so immediately pre-pandemic, showing that subsequently the notifications decreased until last year when they started to rise up to where we are just now. And as Andrew has already indicated, that for year on year, we're already up to, somewhere about 25 times a higher incidence of pertussis than last year. And again, another way of looking at the same data, but this time looking at age groups. So these are data for, now we're looking at incidence. So this is, we're actually looking at incidence. So this is per 100,000. And we're looking at age groups. And we've got a red rectangle around the peak age group in terms of incidence, which is kids, which is the infants from 1 month to children up to about 10 years of age. So that's where most of the pertussis is occurring. And here we've got, we're looking at pertussis in different age groups. So this is, again, Australian data. Again, it's incidence, so notifications per 100,000, and it's showing a trend from 2009 up to 2020. And it shows that overall, there is a decrease in the incidence, albeit with the peak shown here in 2015. So the light blue is for the 15 to 19-year-olds, and the dark blue is for the 20 to 24-year-olds. And again, this is looking at ages across Australia. We're looking at pertussis notification rates. We're also looking at it, so we've divided by males and females, and it looks as though there may be a slightly higher incidence in females than in males. If you look at the red line for females and the blue line for males. So again, showing that the peak is in young children, that 1-year-old to 10-year-old group, but also showing that it is present in older people as well, in adults, not just in children. So just putting some more figures on that, showing that the rates between 2000 and 2018 were significantly less than between 2006 and 2012. So pertussis has decreased over that period of time. More recently, 2016 to 2018, those infants under 2 months of age, now those are infants who've only had one vaccination, or they may have received passive immunization from their mother if she's been vaccinated during pregnancy, but these are the most vulnerable infants. They had the lowest notification rates for children under the age of 5. And the highest notification rates, again, as shown in our previous slides, were in those pre-adolescent children. And very important to note that both notification and hospitalization rates are much higher in Indigenous children compared to non-Indigenous children, and that was for under 5 years of age. Next slide, please. So epidemics do seem to occur every 3 to 4 years. That's not clearly explained, but that's just an observation. 2/3 of cases occur in spring or summer. So here comes the sun, and here comes pertussis. We note that there was an increase of 500%, so a 5-fold increase between 2005 and 2010. And watch this space for how it's going to increase this year, because we've got spring and summer still to come, and we're already way ahead this year compared to last year. And you'll see the figures there. Currently 38,000, and since I've started this session, it's probably gone higher than that. These are United States of America data, similar to the National Notifiable Diseases Surveillance Survey in the United States. And really what they're showing really here is that the incidence seems to be inversely proportional to age. And hospitalization seems to be least in children, those aged from 1 to 19 years. So consistent with what we have in Australia. As I say, pertussis is a worldwide disease. And here we have this again is incidence. So we're looking at cases per 100,000. Again, coming back to our peak in 2011, but showing that since 2011, there has been a decrease in the incidence of pertussis across all age groups. But look at the highest line, that's the green line, which has been outlined in red. That's for the under 12 months. So showing that the incidence remains highest in the infants who we know are most vulnerable to the effects of pertussis. So we're going to look now, next slide please, yeah, at vaccine effectiveness. Fortunately, pertussis-containing vaccines do provide protection against severe and typical pertussis, but less protection against milder coughing illness. So there may be a mild respiratory illness, but not the devastating severe typical pertussis, which is particularly devastating for the young infants. So the DTPA with all the capitals, that's the vaccine for children. So we do see that the vaccine efficacy may be 17% for milder symptoms, but higher for preventing the typical and serious disease. So we're now going to be looking at vaccine effectiveness in adults and in adolescents. So we've now got the reduced antigen content for both diphtheria and for pertussis. So we've got little d and little p, but the same T. And again, immunogenic, including in older people. And vaccine efficacy quoted as about 92%, which is pretty good going for vaccination. So next slide, please. We're going to look now at vaccine effectiveness in pregnant women. So it's been demonstrated that vaccinating pregnant women with DTPA in every pregnancy will reduce the risk of pertussis in the pregnant woman, but also in their young infants due to transplacental transfer of pertussis antibodies. So covering the infant for that period before which the infant cannot receive the vaccination. So if infants are receiving vaccines at 6 weeks of age at the earliest, they're getting some coverage, some protection from mother, which may last for up to 6 months. So enhancing vaccination for the infant. So it's not known what level of antibody is required, and we don't know about how waning immunity affects the mother. But empirically, vaccinating for pertussis in every pregnancy is what's recommended. And next slide, please. So we're going on now to look at the National Immunisation Programme, which we'll be familiar with. So we have a primary course, a primary childhood course of 5 pertussis vaccines, a booster in adolescents between 12 and 13 years of age, and also in pregnancy. So that's what the National Immunisation Programme stipulates. It is different in different jurisdictions, but all jurisdictional schedules are based on the national schedule. Next slide, please. So we're really looking for a target of 95% vaccine coverage for maximum efficacy for individuals, but also for protection within the community, the so-called herd immunity. Can I have the next slide, please? So we're now going to look at that coverage. So how well are we doing? We're going to look at it at 12 months of age, then at 2 years of age, and then at 5 years of age. So the DTPA is the faint pink line, which you probably can't see on the chart, but it's near the top and actually shows that we're doing not badly. We're pretty much getting on the 95% at 12 months of age. So we're now going to look at 2 years of age, and pretty much the same. We are doing well. About 95% of 2-year-olds have been vaccinated for pertussis. They've received a DTPA vaccine. So we're looking at 5 years of age, and perhaps dipping off a little bit, maybe dropping down to 94% in this slide or this chart. The DTPA is the red solid line. So maybe we're not quite getting to 95%, but we're not far off it. And now we'll look again at the coverage in adolescents. So next slide, please. Optimal age, say, is 11 to 13 years. Next slide, please. And we've now got some data looking at the coverage rates for adolescents. So we've got the 2020 in red and 2019 in blue. This is for DTPA, or the Boostrix Adacel vaccine. And if we look at the column on the far right, that's for the whole of Australia. We'll see that we're doing not badly. 87% of adolescents vaccinated for pertussis in 2020, so a bit of an improvement over 2019. And that actually applies across all the jurisdictions as well. 2020 vaccination rates have been higher than 2019, but we're still not at the 95% level that we're seeking. Next slide, please. So looking at adults, for what are we doing now? If we go back 4 slides, please don't go back the 4 slides, but if we were to go back 4 slides and look at the National Immunisation Programme, adults are not on the National Immunisation Programme. However, it's recommended that adults who want to reduce their chance of getting whooping cough should receive the pertussis vaccine. Adults who need a tetanus vaccine because they got a wound are recommended to receive the pertussis vaccine rather than the diphtheria tetanus vaccine. But it's not funded for adults except for women between 20 and 32 weeks of pregnancy in all their pregnancies. Now, interesting, I did a little bit of a look to see if there are any countries that did. Now, most countries will recommend 10-yearly vaccination, so 10-yearly boosters, but it's not funded. And I couldn't find any countries that fund it. So if anyone knows, I'd be interested to get your comments. So that means if it's not funded, individuals are paying for it. The latest I could get from one of the discount pharmacists was a quote of about $30 per dose for DTPA and $60 per dose for DTPA plus polio vaccine as well. So individuals who want vaccination as an adult, unless they're pregnant, are going to have to pay, and those are what they're looking at in terms of being out of pocket. There's no refunds for those at all. I'm not aware if there may be refunds through private health funds. Maybe there are, but certainly they're not funded by the government. So again, looking at, we've indicated that pertussis occurs in older people and they're vulnerable. And the recommendation is that for people who are 65 or older, that they should receive a pertussis-containing vaccine. Next slide, please. We've talked about women who are pregnant and breastfeeding, who should also are recommended to have the vaccination, and that's on the National Immunisation Programme and has been jurisdictional since 2015. And what about contacts? Protecting themselves, but particularly protecting vulnerable infants. So infants who are under the age of 6 months are at high risk. So the adults who may be in contact with them, so that may be the other parent, maybe grandparents, maybe siblings, they're recommended to receive the vaccination, allowing at least 2 weeks before they have close contact with the infant to allow sufficient antibody development in that period of time. And also, healthcare workers are recommended to receive a pertussis-containing vaccine every 10 years. And if you're working with a health service, they may fund that for you, but otherwise, you're really going to be out of pocket for that. And similarly, childhood educators and carers, so who maybe will be or may be in contact with young children and infants, they're advised to have the vaccine every 10 years as well. So again, moving on, so we're jumping around the age groups just a little bit here, keeps us on our toes. So going to talk now about adolescent pertussis vaccine. You may recall on an earlier slide, we saw that we were making about 87% of Australian adolescents vaccinated against pertussis. So what can we do to, if anything, to improve on that. So young people may miss the school vaccination visit, or they may choose not to have it during the school visit. So all of us as vaccine providers have a responsibility to ensure that students who missed it get a catch-up vaccine. And that can be done in an organized way, or it can also be done opportunistically. So we can check the Australian Immunisation Register, and we can see if a child, or a young child, an adolescent, has not had their vaccination, and we can offer that to them so that they get the relevant booster. Next slide, please. So the World Health Organization had developed what they called the Decade of Vaccines, 2011 to 2020, in which they were advocating for a world in which everyone, individuals and communities, can live free from vaccine preventable disease. So that's something to aspire to, but we're not there yet worldwide. So this is about equity, ensuring or aiming for immunization to be accessible to everyone, and so that populations can benefit. So that's a system issue. As providers, we're at the other end of provision. We're giving the vaccines. We're not organizing policy, but we can contribute to advice and helping to deliver the vaccines. So we're going to talk, and the rest of this session will be around older people. Not surprisingly, pertussis is not a childhood disease. We've shown that with our previous charts. Here's a great word, immunosenescence. And if you're interested, I actually counted that there are 16 letters in that word, so immunosenescence. So it's really where the immune system starts to wear out. So, and if I could have the next slide as well, please. So here we have, and this is a variation of the slide that we had seen previously. So again, we're looking at, this is actually incidence, so it's notifications per 100,000. And rather than looking at the blue bars, if we look at the red line from left to right, again showing our peak in that child age group, but you'll see that the red line doesn't disappear after childhood. The red line runs all the way up to and including the over 75s as well. So pertussis does happen in adults. Could I have the next slide, please? And we know that immunity after vaccination doesn't last forever. And if I look at the right side of the diagram on the chart, which looks at the acellular vaccines that we currently use, protection probably lasts for 5 or 6 years. So if a vaccine has been given in adolescence, by the time the adolescent reaches the age of 25, the immunity is pretty much worn off. If you go to the middle of the diagram, the older cellular vaccines offered better protection, but they were associated with significant safety concerns around neurological adverse effects, so they're not used, although they are used overseas. Again, I couldn't quote which countries, but they are still used overseas as well. So what is immunosenescence, apart from being a 16-letter word? Essentially what it's saying is the immune system is wearing out. So you've got fewer T cells. The ones that learned immunity previously are exhausted, so they can no longer fight infections. So overall, there's a decreased response also to all vaccines. And the other issue we've got comorbidities that as people get older, we tend to accumulate other morbidities, and I'll address those shortly. So here we go. Immunosenescence has an impact on our incidence and prevalence of disease, and also on disability. We have vaccines for influenza, pneumonia, pertussis, and for shingles, but we're not perfect in getting them to the individuals who would benefit. And we've looked at the if you like, how many older people are getting vaccinated. and we're doing pretty well with influenza, not badly with shingles, okay with pneumococcal, but we don't know where things are at with pertussis. So I'm not sure why that is, because I thought the data were being collected through AIR, and someone could perhaps help me out with that in our discussion afterwards. So this is helpful. We underestimate pertussis in adults in general, but particularly in older adults who are the most vulnerable adults. So we perceive that it's a childhood illness, but it's not. The symptoms may be atypical. So we talked about the typical catarrhal stage, the paroxysms of coughing, the vomiting, the pooping, the persistent cough. That may not be the case. In adults and older adults, there may not be a whoop, there may not be any vomiting, there may be fewer paroxysms. So it may not be the classical symptoms that we see in children. The later the diagnosis, the more difficult it is to make the diagnosis. So people might not be presenting until they've had a cough for 4 or 5 weeks, and by which time you've missed the opportunity to take a swab, a nasopharyngeal swab for PCR. Culture is not helpful at that stage, so you're really left with a clinical diagnosis and serology to identify IgA. IgA is useful because it's produced by pertussis illness, but pertussis disease. It's not produced by vaccination, so IgA can discriminate between vaccination and between the disease. And here we are. This leads on to what we're talking about. There are really 3 ways, well, 4 ways of diagnosing pertussis. The one that we haven't got there, which is important, is clinical, which is really our red flag and awareness of the disease. So the nucleic acid amplification test, so PCR is the most common. That's really useful in that sort of catarrhal stage. But the sensitivity reduces after 5 days of antibiotics, so false negatives are higher. Culture is the gold standard, and it has good specificity. That means that if it's positive, it's positive. It's a good relation of being actual pertussis disease. But also, it's not sensitive. So that means there are a lot of false negatives. So can get a negative result even though there is pertussis. An IgA antibody, so that's the sort of the mucosal antibody, that develops probably 3 weeks after cough onset. So that can be useful even up to 12 weeks after the onset of cough. You've probably heard of pertussis being called the 90-day cough or the 100-day cough, and that's pretty much right. And it's also worth mentioning, what can you do to relieve symptoms during that period? There's no place for antibiotics because we know that they're of no efficacy from 3 weeks after the onset of cough, so there's no place for antibiotics. So what else can we take to help? And the answer in one word is nothing. Because there's been nothing that's been proven to reduce cough in that convalescent stage of pertussis. So again, this is showing that yes, it really does happen in older people. So this is a serology study. It's quite a long while ago, back in 2000, so 24 years ago. But this is looking at just 100 adults, and actually found that based on serology, there was evidence of pertussis infection in 8%, at least probable pertussis infection of these adults, and definite pertussis infection in and 3%. And of those with the definite pertussis, half of them were symptomatic. So symptomatic pertussis does occur in older people, and therefore pertussis vaccination should be considered. And there are other reasons why it's important for the elderly. Could I have the next slide, please? And the other reason is because older people tend to get sicker, particularly if they have got one or more comorbidities. And this again is a figure from the United States. It's looking at 2011 to 2015. And if we look at the darker blue column in the chart, this is telling us that 87% of older adults who were hospitalized with pertussis had one or more other medical conditions, such as obesity, asthma, diabetes, cigarette smoking, COPD, heart condition, kidney condition. So the more comorbidities, then the higher the chance of getting more sick and needing hospital care. So this is looking at two things. This is looking at obesity and taking supplements or medications. And again, showing that older people who take supplements or older people who are obese are more likely to be hospitalized with pertussis. This we're almost finished, so thank you. We're going to look at vaccine effectiveness, and this really echoes what we looked at in that chart earlier, and that vaccine effectiveness wears off with since it's been given, wears off with time. So the vaccine effectiveness in the first couple of years, or the first year, maybe 80%, 84% after 2 years, but then it starts to drop off. So that if it's more than 8 years since the vaccination, down to about 40%. So this is the problem that we've got for older people. We haven't got the protective antibodies. There's lots of disease around. Mortality exists, not just in infants, but in older people as well. And we need vaccination. So how do we get vaccines to the people who need it? Next slide, please. There have been various strategies. How can we do that? Incentivizing opportunistically, providing information, public health information, public health programs. So getting the word out there that it's beneficial and it's effective. So providing information, providing encouragement. And this is us. So it's us as pharmacists, as medical practitioners, as nurse practitioners, maternal and child health nurses, midwives, Aboriginal health practitioners. All of us have a role in maximizing the uptake of all vaccinations, but pertussis vaccination in particular, particularly in adults and older people. It's become a little bit of a sort of an orphan, and it's really it's our responsibility to pick that up and to help with it. So really, I guess the summary comes back to what I said 45 minutes ago, which is think pertussis. It's there in all age groups, and vaccinate. And third thing, vaccinate again. So it's not just the primary course. It's think about vaccinating every 10 years. Think about vaccinating in the older people who may not have been vaccinated since they were kids and may not have been vaccinated at all. There we go. And there are references which will be for you. Please don't copy those down. They'll be on the slides. So thank you. That concludes the show. I hope there will be some questions that we can look at, and if I'm unable to answer, we can take questions on notice and we can get back to you with answers.
Thanks very much, Andrew. That was more than a good show. So you covered absolutely everything. We have a lot of questions here, but I'll start with one question, or the initial question. So for the under fives, the vaccination rate against whooping cough is good. With
correct.
Under 5, under 2, and under 1, they're all up around the 95%, range between 92 and 96, and it's a bit state specific. We have a school vaccination program at 12 and 13 years. And adults, there is no eligibility on the NIP for free whooping cough vaccination. We've got a very high case number this year at 27,000. Who's not being vaccinated? We've got children from 9 till 15, which are the predominant cases, but they were vaccinated at under 5. I thought the period for efficacy was 10 years, but it seems to be less than that, and we're all being told that it's 10 years. So what's the answer to controlling the amount of whooping cough in years like this and targeting specific age groups? Is it, what is it?
Great question, and I can't provide the answer. I haven't got a breakdown of the incidence by age for 2024, so I don't know, and I don't know if you know, Andrew, which age group is is our reservoir. But I think we can say it's in the community. I don't think it's particular sectors necessarily, and there'll be those higher prevalence perhaps in these school children, young children, and adolescents. I agree. It does seem difficult to explain that when we've got 95% up to the age of 5, what's happening between 5 and 11 when the booster is given. I don't know. I don't know.
Yeah, and it'd be good to have air data, which
Sure.
we just don't have it. So that's the
Yeah, I agree. Yeah, that would be really helpful. So I think struggling to find an answer when we don't really have enough information on which to make a comment.
Yeah, and on the private script at $30 and up to $60, if you break it down, per year, and it lasts for anywhere from 5 to 10 years,
Sure.
talking, a quarter of a cent a day. But I mean, we always
sure. That might be one way of marketing it and presenting it, Andrew, to sort of put it that way. Because $30 for some people that's just going to be nothing, and for some that's going to be that's going to be a few meals, that's or worse than that. So I know it's really difficult.
Yes. So I have a question here and there's like 30 questions to get through. So from Catherine, it's an FT question, first time question. So I didn't notice that, Catherine. Yes, 7 student presents approximately 4 months post pertussis diagnosis. Do you need, or what time do you need to wait after to vaccinate with Boostrix?
Yeah, that's a really good question. The best time to vaccinate in those, this is not the case for all vaccines, the best time to vaccinate is now. So you've got because it's not like, say, I guess the common one we think of is shingles, where you wouldn't give a shingles vaccine for 12 months. But in this case, if the child has had proven pertussis, you don't wait for 12 months, and you take the opportunity to give that now.
There's another question here. There's a number of them. What's the reason in some cases someone's experienced that their patients are getting pertussis every year for 2 to 3 years? It doesn't say whether or not they're vaccinated, but they're getting it every year for 2 to 3 years. Any explanation around that?
I don't know. Unusual that because if you're getting pertussis, if you're getting the native infection, you are getting some immunity from that. You are developing antibodies, and we know that they would last. They typically for 8 to 10 years. So you should have some immunity. So I don't know. That's unusual. I think you would be saying that's sufficiently unusual. You certainly want to confirm that it is pertussis that was happening annually, and it's sufficiently unusual. You'd be saying, is there a problem? Is there some immune problem here that you're not developing adequate antibodies? That is really unusual.
This is an air question, really. Do we have any data on the uptake of vaccination for pregnant women? So we don't, do we?
No, we don't, because we don't capture that data. We will capture the data that a woman has been vaccinated, but it doesn't capture they're pregnant.
This might be a good one for you as a GP. This is from Megan. With community pharmacies now offering the DTP for some time, what role do you see pharmacists playing in helping increasing vaccination rates? And how would you suggest they encourage uptake of boosters?
I think pharmacists have got a fabulous role, a very important role in improving uptake. And I mean, pharmacists have already shown how well that can be done with influenza vaccination and COVID vaccination. So I think it's using those sort of principles and approaches would be great. I think that should absolutely be done, and whether they want to, sort of advertising that as they've done with other vaccines, that they've got the capacity and capability to do that, to say that they are able to give DTPA. I think the more the better, the more we can offer people. So whether that's through schools, through general practices, through pharmacists, I think that's I would support that. Just me speaking, but I think you'd find that many healthcare practitioners would be saying the same thing. It's not a matter of competing at all. It's a matter of providing more accessibility and more equity, and I think. I believe pharmacists would be great for that role.
An FT question here from Donna. This is there any conversation around making booster doses affordable to adults? I'm not sure if this is a manufacturing question, or a manufacturer question, or a government question, because at the moment there's no conversation to add it to the NIP.
I think Andrew's answered that. I think that I think we can make a very good healthcare, health economics, legal, ethical argument for government funding, but it's not on the agenda. It hasn't happened.
No, but a more targeted approach for those that in that age group that are getting pertussis this year. This year is a 5-year. It could be it's every 3 to 4 years, but looking back in history, they have a 2-year cycle. So if we're going to do something and press the point to government, this would be the time to do it. So I think that's something that we'll look into. But we do write to government in the last couple of months advocating for free whooping cough vaccination for targeted groups, the risk groups.
Yeah, thank you, Andrew. You're the health minister. I'm voting for you. Yeah.
All right. I'm just going to run through them from Hina. So for contacts of newborn, when a DTPA when is a DTAP recommendation for newborns, for contacts of newborns? I guess this is parents and grandparents, I guess.
Yeah, I mean, the recommendation is that the grandparents, siblings, other parent should be vaccinated at least 2 weeks before they have contact with the infant. Does that answer the question, Andrew? Is that what?
Yep. So it's from Alison here. Private health funds cover items over $30 greater than on the PBS on average, so you might get some joy from your health fund on vaccination here.
But I think that's my understanding is that's for items that are on the PBS greater than 30. So it's not on the PBS. That's the problem. God.
That's right. Okay.
Yeah.
If the pregnant woman receives between, I guess it's 32 to 23 to 32 weeks or whatever it might be, receive the vaccination during pregnancy, do they need another dose during breastfeeding?
No, they don't. No. So no, they're covered. That's a good question. Really good question. They certainly need another dose in another pregnancy because you're helping the next baby, but not if they've had the vaccine, and it's usually between 20 and 32 weeks. Often given at 28 seems to be fairly standard, but any time between 20 and 32, if they've had that, that will cover them for the breastfeeding period as well.
Yes. Is there any recommendation for more frequent vaccination for people who are immunocompromised?
That's a really great questions. Thank you, everyone. That's really great. And the answer is no, but they certainly should be vaccinated. So I think that would be vigilance to ensure that they're getting their vaccines every 10 years. There isn't any recommendation that they should have a stronger dose or more frequently.
This is from Kate here. I'm just trying to get through the questions as quickly as I can. I had 2 elderly grandparents patients today, 6 and 9 years since their last pertussis booster. Just wonder whether they should receive their booster soon, as they always thought it was a 10-year period between shots.
So the answer is yes and yes, because they're right. It is every 10 years, but we know in older people that the immunity wears off. Now, I can't make I'm not going to make a clinical decision on that, so I'll speak hypothetically. I mean, if there were the situation where you have an older person who has had a pertussis vaccination, 9 years ago, and they present today, it would be a really good idea to think about giving it. Rather than waiting a year, during which time they may get pertussis because their immunity has dropped off. So it's not a contraindication. And when you think of it, if pregnant women are getting the vaccine, if they have pregnancy every 2 years, they and 4 children, they've had 4 vaccines within 8 years. So it isn't an issue with giving it too frequently. So again, I can't give clinical advice, but I can say it's worth thinking about.
Okay. From Linda here, is a pertussis cough productive? Can a sputum sample be useful, or is the PCR swab gold standard?
Oh, thank you. That's a really good question. All good questions. The PCR is probably not a gold standard, but it's as good as you get. Sputum, no. Sputum, you won't get it. You'll get a lot of mucus, and you'll get a lot of lymphocytes, but that's really about it. You actually need to swab the mucosa. So a swab, preferably nasopharyngeal swab. They're pretty unpleasant, so a pharyngeal swab would be a reasonable compromise, and that really has to be in that so-called catarrhal stage, which is difficult because that's really before the classical cough has developed. So good question, but and is it productive? No, it's typically a dry cough, except in that catarrhal stage. Then you may have a wet cough during that stage. And it's hard to get sputum from an infant. They just tend to swallow it.
Running short of time here, 7:01. I'm conscious of people's time, and I'll just have one more question. I'm sorry I couldn't get through them all, but we will respond to those questions, and we'll send them out as the transcript within 1 week. So we will get to them. This is kind of self-explanatory, this one. Can pertussis be notified on clinical diagnosis? I don't think so. Or do we need to have a lab confirmation?
No, you don't. You can absolutely, you can notify on clinical grounds. And I'm glad that question has come up, because we need data, and to get data, we need notification. So please notify, and you notify on clinical grounds. Great if you've got backup, that's fine, but it's not mandatory. You don't need to have the confirmation.
Sorry, Katie, I got that one wrong. So I made an assumption. So I'm going to have to draw it to a close because it's 7:03. I'm sorry. Some of you have asked me to repeat a question because it wasn't clear enough. We will get back to that. Just in the last 2 minutes or less. First of all, thank you, Dr. Baird, for providing your wonderful talk on pertussis, and also for answering all the questions in kind of a rapid fire session. So thank you very much, and it was a really well-rounded presentation. Just a plug for next month's meeting. We have our second primary care infectious disease meeting in Sydney next month on the 19th. It's at the Park Royal in Darling Harbour. It is free. It's accredited. It's a hybrid meeting. So if you look on our website, you'll be able to see that. GPs, nurses, and pharmacists are welcome to attend on site. There is a limitation of just 100 on site, and the rest will be online. And then the next IC webinar will be on shingles. That's on the 20th of November, and that's by Professor John Litt. So those are our 2 last education meetings for the remainder of the year. With that, actually, just if you can fill out the evaluation form, that is helpful for us. We do look at those and see where we can improve. So with that time, at 7:03, again, thank you, Andrew. You might want to say something to the audience before
yes,
we...
many thanks for your participation and your attention. Thank you, and thank you for the fabulous questions, which are very challenging, and I look forward to answering the rest. I wish you well. Have a pleasant evening. Take care and stay safe. Thank you.
Yes, stay well, stay safe, and see you soon. Thank you very much for joining.